Okay, we're going to begin today with Chapter 4 in your insurance textbook, page 60. And just bear with me because I am losing my voice, so I'll try to talk as clear as I can. We're going to start with processing in the insurance claim, the bottom of page 60. Insurance claims, I think we talked about in the lecture for Chapter 3 that they used to be called HCFA, HCFA, and now that's changed to CMS. So insurance claims now are called CMS 1500 insurance claims, and you can see a picture of that on page 61. These can be manually done or they can be electronically done, and more commonly now they are electronically done. And basically this is what these are filled out to basically show send to the insurance company for reimbursement. And we'll talk more about this as we get deeper into the financial aspect. Look down to accept assignment. Again, with all these key terms, you do need to know these. Accept assignment means that the provider has contracted with the insurance company and they have agreed to accept what the insurance company reimburses. So, like we talked about with Chapter 3, if the office charges $50 for a vaccine, the insurance only pays $30. The physician has to accept the $30 and cannot charge the patient the difference of that. And so that's what accept assignment means. Now, patients may have out-of-pocket payments, and that's totally normal. You have your co-payment, or you may have your deductible. This thing sure is foggy. Anyway, we'll keep going on, and hopefully it will not be so blurry. An out-of-pocket payment, basically, usually for most insurances, that the total out-of-pocket payment for the year is $1,000, and some have $2,000 too. It just totally depends on the insurance. So that's what the out-of-pocket payment is, what the patient is responsible for. Let's keep going on here on page 62. One thing with insurance companies that usually lasts like the first year that you are covered under the insurance is called a pre-existing condition. And a lot of insurance companies will not cover pre-existing conditions for the first year that the patient or you have the insurance. And that's anything that you've been treated for. So, for instance, if you have high blood pressure, anytime you go to the office and it deals with high blood pressure, or in the hospital, and for high blood pressure, the insurance will not cover it until the full year has gone through, and then they will cover after that. And so that's what the pre-existing clause is, and that's usually with most insurances will have that. Let's look at management of accounts receivables. Accounts receivable management is basically going to be your accounts receivable person in the office. They're the ones that's going to be accepting the payments in the mail and posting the payments to the patient's account in the office. So they'll keep them up to date, and they'll track the claims to see if they're being reimbursed and making sure that they're reimbursed in a timely manner. So that's what accounts receivable management is. Before the patient is seen, you usually have to do an insurance verification form, and this is going to be one of your competencies. You can see that on page 62. So just look over that, and we'll do this in class later on. Going on to completing a CMS 1500 form. This is where you get into the nitty-gritty of billing, coding and billing. The signature on file that it tells you about. This is that doesn't mean that you have to have the patient sign the claim form. It just means that you can actually put SOF or the whole word signature on file in all caps on the CMS 1500 claim form. And if you have that, that means that the patient has signed something in their medical record saying that you are allowed to bill their insurance company. And so, again, you do not have to have the patient to literally sign the claim form. As long as you have their signature somewhere in their medical record, you are good. So that's what the signature on file means. When we send claim forms and things to the physician, to the insurance company, we also have to send some forms of documentation. So the insurance company specialist, person that's reviewing the claim, can actually read the physician's note and determine if, what the payment is, the payback for the physician is going to be. Let's see. If we have a non-participating provider, a lot of times with that, when you do the claim form and you have that difference between the allowed amount and the actual amount that the physician charges, without a network providers, the physicians are allowed to bill the patient the difference between what they charge and what the insurance is going to reimburse. So again, if the physician charges $50 for a vaccine, but the insurance is only going to pay $30 of it, then they are allowed to bill the patient the remaining $20, and that's for only non-participating providers. Okay, let's go on to managing new patients. This patient, when a new patient comes in, this is when you have to get all the necessary information. You have to get all their medical records. You need to get all of their insurance information. Okay, sorry about that. This is where you have to get all their information, their insurance card. You have to copy front and back, and you start their verification process of the insurance. Let's look on page 64. You have the steps of new patient, checking in new patients. You have to pre-register the new patient, and you can see on page 64 all of the different things that you need. And we talked about yesterday the different names for the person that has the insurance, and this chapter is calling it the guarantor, but it can be called the policyholder, several different names. But that list is all of the things that you need to get when they come in as a new patient. Now, sometimes for new patients, a lot of offices will mail the patient the paperwork. That way they can go ahead and fill it out, and then when they come in, they can have it ready and good to go. Or, sometimes the office may say mail it back, or come by before the appointment and drop it off. That way it's already done, and then when you come in, you can just wait for the physician, not have to fill out any paperwork. Let's see. When your new patient does come in, you need to make sure that you inform the patient of all the office policies, like your billing policies, your appointment, your no-show policies, anything like that. You need to make sure you tell the patient that. Participating provider, the PAR, is a physician that contracts with the insurance plan and accepts what the plan pays, like we talked about just a few minutes ago. And again, it is unethical and illegal for a participating provider to accept or to charge a patient the difference between what they charge and what the insurance pays. But then again, the non-participating provider, they are able, and it is ethical and legal for them to charge the patient the difference. Okay, so let's look at step 2 on page 65. Step 2 is you have the patient complete the registration form. Step 3 is you photocopy the front and back of the insurance card. Step 4 is you confirm the patient's information, insurance information, and eligibility, and you usually have to, sometimes you can do it electronically or you have to call and verify. It just depends on what kind of system the office has. Step 5 is you enter all the information into the computer, verify the information, and make any kind of changes that are needed. When a patient has more than one insurance company, so let's say they have a primary insurance and a secondary insurance, a term called coordination of benefits, or COB, comes into play. And this basically means they got to figure out which insurance is going to be primary and which is going to be secondary. Now, some insurances like Medicare, Medicaid, if a lot of elderly patients have that, those are predetermined. So if a patient has Medicare, Medicaid, Medicare will always be primary, and Medicaid will always be secondary. So some insurances have it already set up, but if not, then they have to do the coordination of benefits. So let's look at page 68. A lot of times, if we have, let's say, we have a child, mom and dad both have different insurance companies, we use what's called the birthday rule. Whoever's month of their birth falls closest in the year will be the primary. Whoever falls second in the year will be the secondary. So that is usually how we figure that out. Primary insurance usually, and when we do the coordination of benefit, the most common way that this is done is the primary insurance will cover 80% and then the secondary insurance will cover 20%. But it's unlawful to, and illegal to bill both insurances the same amount of money. And I mean, the patient is not allowed to withhold any kind of information. So let's look at child of divorced parents, the middle of page 68. Whoever is like the custodial parent or the main parent is going to be the primary insurance. And we already talked about the birthday rule. And some insurances may include the gender rule, and this is basically that the father's plan, it just says that father's plan is always primary. This is not commonly used. We usually do the birthday rule instead, because a lot of times the mother will be the main custodian of care. Okay, so going on to step 6, we're going to create a new patient medical record. Step 7, we're going to generate the encounter form. Now the encounter form, as you can see in figure 4.5 on page 70, is like the billing form. It's going to be the form that you'll fill out, the physician will fill out, and you're going to list all the diagnoses, any procedures that were done. And so this is going to be the main one that the billing specialist is going to use to accurately bill the patient or bill the insurance company. So the encounter form, it's also called the super bill, usually in a physician's office, and in the hospital it's called either a charge slip or a charge master, but they all mean the same thing. Basically, after we get the encounter form, we generate it, we want to print it out and put it on top of the patient's medical record. So when they go back to see the physician, it's already there and it's ready to go. Let's look at managing established patients. So we talked about new patients, and so let's talk about maintaining established patients. So step 1, you want to schedule a return appointment, if at all possible, when they're leaving for their most current appointment. Let's look at step 2 on page 71. You want to verify the patient's registration information when they register at the front desk. Okay, a lot of people move, a lot of people change their numbers, a lot of people may change insurance. So with established patients, you want to make sure that you ask them, has there been any changes in insurance, address, phone numbers, marital status, whatever. You need to make sure that you ask the patient that, and then update the record if there is a change. Let's see. Step 3, you want to collect the copayment from the patient. Step 4, generate an encounter form for the patient's current visit, and again, you're going to print the form out and put it on the medical record. So now we've talked about new patient, established patients, so let's talk about the actual financial part. So we're going to get into managing office insurance finances. Step 1 is you want to assign the CPT or the procedure codes to the procedures and services that you've provided. And then the physician will usually list a diagnosis down there. And then occasionally they'll put the ICD-9 code. But if they don't, then you'll be responsible for looking up the ICD-9 code or the ICD-10 code in the future and putting it on the encounter form. Now, anything you want to make sure that you pay attention to this. Anything that is listed on the encounter form must be documented in the medical record from that visit. If it's not, then legally the physician cannot bill for that, and it cannot be on the encounter form. So if it's on the encounter form, it has to be in the documentation from that day. Alright, step 2, you're going to enter charges for procedures and services performed, and then total the charges on the encounter form. Okay, so we'll have, this is done basically so when it gets to the billing, they don't really have to do anything. They just, look at it, they enter the charges, and they don't have to do any kind of calculations or anything. And then step 3 is you're going to post all the charges to the patient's ledger and their account record, and the daily accounts journal. And a lot of people still do this manually, but now, thank goodness, it's getting to be electronic, and it's a lot easier. So the patient ledger, if you do it manually, you can look at figure 4.6, and that is an example of a patient's ledger, and it's usually in numerical order by chart or in alphabetical order. And so if you do it manually, we have to go and pull their ledger and make sure that we document appropriately. Let's go on to page 73. The manual accounts journal, this is called the day sheet on figure 4.8, and basically a day sheet is used to, if you do it manually, the day sheet is used to see all the day's totals, whether, co-payments, charges, etc., etc. And you can do this electronically too. You just generate, all the activity for the day and print it out. So it's a lot easier when you do it electronically. Step 4 is you're going to bill the patient's insurance policy and then bill the patient for the co-insurance amount after the payment from the third party is received. So if the patient is responsible for 10%, you cannot bill for that 10% until after the insurance has paid the physician. Then you can bill for the 10%. You can also, step 5, you post the payments to the patient's account. So when we need to put how they paid, did they pay by credit card? Was it Visa, American Express, whatever? Did they pay by check, money order? How much was it? What was the check number? So you need to know all that information manually, if you're doing it manually, and if you're doing it electronically. Then step 6, you're going to complete the insurance form. Step 7, you're going to attach any documentation that supports it to the claim. Step 8, you're going to obtain the provider's signature on the claim, and if it's manually processed, usually what we do is we have a signature stamp. If it's electronically processed, we usually have an electronic signature, so you don't physically have to go and have the physician assign it. Step 9, you're going to file a copy of the claim and copy of the attachment in the practice's insurance files. And then step 10, you're going to log completed claims in an insurance registry. So, and that's figure 4.9. So when the completed claims are done, you want to do in the registry. And then step 11, you're going to either mail the claim or electronically send it. Alright, so let's go on and talk about the claim life cycle now. The claim life cycle has 4 stages. The first stage is the claim submission in the EDI. The second stage is claims processing. The third stage, which is probably the most important stage, is the claims adjudication, and then the fourth stage is the actual payment. So when we have claims that when you can actually look on insurance websites and see what your claims, what the status of it is. And so if you see a pending status, then that means that a final decision hasn't been made on what they're going to reimburse the person. Sometimes you may see a claim that's denied or rejected. A lot of times it's just like a typographical or administrative error, and then sometimes it can be, more severe, like if the patient had to have a CAT scan and they didn't do a pre-authorization, they're not going to pay for it. So you're going to see all those different types. A clearinghouse, when we do a claim submission, we have something called a clearinghouse, and this is either a public or private service that's done that will, where you can actually go in and see everyone in your practice, all their claims. Because if not, you have to go to, these certain people may have Blue Cross Blue Shield, these people may have Aetna, these people may have whatever. So when you have a clearinghouse, you can see everybody's stuff all together, and it tracks your claims. It helps with that. And then we have a value added network, or a VAN, and this is very efficient, and it's a lot less expensive for providers than managing their own systems. And so a VAN is even better. So when we're looking at VANs and clearinghouses, you want to make sure that they are accredited. When they're accredited, that means that they, have that respect in the community. Let's look at electronic data interchange, or EDI. This is a computer-to-computer transfer. So sometimes if you see a lot of stuff on the computer that doesn't make sense when you submit something, it's communicating from electronic format to computer. So that's what this EDI is called. Let's look at HIPAA real quick at the bottom of page 76. This HIPAA is very important. That goes along with the claim form, the CMS 1500. And basically with this, you're going to improve the effectiveness of the healthcare system overall. And so you have you can look at the eligibility for a health plan. You can look if they're still enrolled in a health plan. You can see when they were first report of injury to see if it's pre-existing. So I mean, you can see all different kinds of things. Those are just some of the things that you can see in like these big clearinghouses and VANs. Let's look at covered entities on page 77. Covered entities include any private sector healthcare agencies, like managed care, the ERAs, things of that nature. And these are considered to all transmit and accept things electronically. Let's see. Let's look at some of the advantages for electronic claims processing. You have a reduction in payment turnaround time, so it's going to shorten it. So instead of manually having to fill it out and then mailing it in, the snail mail, and waiting for the reimbursement, you usually get it back in a few hours, or sometimes a few days to weeks. A reduction in claim submission error rates because it's automatically being done in the system. Paper claims are going to be more prone to error because when you fill out paperwork, you can make a lot of errors very easily. Let's look at the term clean claim. When we have an audit or the edit process, we want a clean claim, and basically this contains all the required data elements needed to process and pay the claim. Okay, sorry about the interruption again. I forgot where we were. We were talking about clean claims. Let's go on and talk about claims attachments at the bottom of page 78. A claim attachment is basically a supporting document. So, the patient's visit to the office that day is what we'll have to send along with the claim. You used to not have to do this, but it's going to be required now for a lot more insurances. For every insurance, and this just gives it decreases your denials when you have the good documentation to support it. Okay, so they're gonna they may also ask you, if for some reason you're denying one of their, or you're appealing one of their denials, they may ask you for previous documentation in the medical record too, and so you can send that as well. Alright, so let's look at how to avoid resubmitting claims. The big thing is you want to make sure that everything is accurate and that everything links appropriately, so the diagnosis links with the procedure. Okay, so we have the term delayed claims, and this means that it's being delayed. Either you're busy at the office on that end, but usually it's because we're waiting on documentation from the insurance. The insurance is waiting on documentation, or something of that nature is happening. We already talked about coordination of benefits. Well, let's look at claims processing. Claims processing is sorting claims as to, this group, these are the ones you sent and waiting on a response. These are pending. These are open claims. These are closed claims. So you're categorizing them basically. Let's look at claims adjudication, which is one of the most important steps. Claims adjudication is where the claim is compared to payer edits and the patient's health plan benefits. And so this is like where they're actually looking into the documentation and deciding what they're going to pay based on what benefits you have. So you have to have the required information. You have to have the claim and make sure that it's not a duplicate. You have to make sure that you follow all the rules and procedures of the payer or the insurance company. And then you want to make sure that they're all covered benefits to make sure that that step in the claim processing goes correctly. Look on page 82. You can have non-covered benefits, of course, and that is a key term, but obviously that's self-explanatory. A non-covered benefit is going to be something that the insurance company is not going to cover, and so you're going to have to come out of pocket for this. And then you have a term called unauthorized service, and this means something that was not pre-authorized before it happened, and so the insurance will pay very little, or more commonly not pay anything at all. Okay, and then let's go on and talk about, we kind of already talked about allowed charges, but I did want to tell you again that allowed charge is what the insurance will pay the physician. Okay, so the physician may have their own fee. Let's say they're charging $100 for a chest X-ray. The insurance may only pay $30 for that. And so that's the allowed amount, basically. All right. So that's the maximum amount that the payer will reimburse. And usually it's not even that amount. It's a percentage of that amount. And then so that $30 that they're going to pay, the allowed amount, they may only pay 80% of that, and then the patient is responsible for the other 20% of that allowed amount. Then we have the deductible, and this is the amount that may be due at the beginning of each year before services will actually start kicking in. Then we have co-insurance, which we've already talked about. And so, again, with the example, we may, the insurance may be responsible for 80% of the allowed amount, and then the patient may be responsible for the other 20% of the allowed amount. So after the claims adjudication has finished, then the insurance company will send remittance advice to the physician's office, and they'll send the EOB, or explanation of benefits, to the actual patient. Alrighty, let's look at payment of claims on bottom of page 83. And actually I just said this, once the adjudication process is done, the remittance advice is given, sent electronically to the physician's office, and you use this to post payments and all that good stuff. And then the explanation of benefits is sent to the patient. Okay, and so on page 84 you can see both of those. And we'll be, in your workbook, you'll be doing some interpretation of these. If the claim was denied, it'll tell you on the remittance advice. If it's needing more documentation or pending, it will let you know on the remittance advice. So your remittance advice is really, really important. Let's see. The electronic funds transfer on page 86. This is basically so, the insurance, instead of sending the physician a check, they will have access to their banking account to where they can just deposit the payment into the account. And then it's electronically done. There's no runs to the bank or anything like that. It's all electronically done. Let's look at some state laws. The Prompt Payment Act of 1982. This is basically this puts a requirement on insurance companies to pay within a certain time frame, and it shouldn't be after that time frame has expired. Let's see. Then we have maintaining insurance files on page 87. The law requires that you maintain all insurance files for, I think it's like 6 years, I believe. And so you have to keep it for 6 years. Now, what they'll let you do is they'll let you keep a source document instead of keeping, everything from that visit. They'll let you keep a source document, and the source document is basically all the necessary information. It may be the encounter form, the super bill, whatever it's called, and to give us the basic information. Okay. It's recommended that you have 3 different separate files for claims. You should have open claims, closed claims, and then your remittance advice. So your open claims are ones that you're still waiting on payment for. Your closed claims are finished, they've been paid, they're done. And then your remittance advice are the things that you've received and that you need to post. And then you may have a remittance advice that you've already completed, but you want to keep the remittance advice anyway. And then you have unassigned claims too. I'm sorry, I skipped that one. These are for claims where physicians do not accept assignment for certain insurance companies. And so they'll have like a whole separate file for them. Okay, tracking unpaid claims. This is really important because if we can't get these claims paid, then the office is losing revenue. So you have to maintain a paper and an electronic copy of each claim. Okay, so it's saved in the computer, but you need to print it out and save it in a file as well. You need to log information about claims submitted in a paper-based log, basically. You need to review the remittance advice to ensure the accuracy of reimbursement. And sometimes everybody makes mistakes, and so if you don't agree with it, then you can obviously contact the insurance again to make sure that they correct the error. If you have to do some kind of reconciliation with the remittance advice, you are able to do that, and you'll need to keep that like in a separate file. Now, if you're appealing, the appeals process, an appeal is basically some kind of documentation saying that you do not agree with the decision that's being made and you want reconsideration, basically. Further explanation. So if we're wanting to appeal a denied claim, we have to be extremely careful. All right. Some of the reasons, the most common reasons why we have a denied claim is the patient either has a pre-existing condition, there's an error on the office's part, the procedure may have needed a pre-authorization, it could be an out-of-network provider, so there's several different reasons why a claim could be denied and the patient may appeal it. All right, so one of the things I mentioned is I didn't mention, but the procedure or the service that was done was not medically necessary. And it may have been, but you may have improperly linked it together on the claim form. And if you do that, it will definitely deny the claim. And we're going to practice some of the linking to make sure that you're doing it properly. in class. The pre-existing condition we've already discussed. This is a condition that you've had before the insurance took place, and usually you have this clause for the first year of your insurance. A non-covered benefit, pretty self-explanatory. Termination of coverage, meaning, if you have left your job or you quit your job, your insurance may terminate at the end of that month, and so you're going to have this as probably an appeal. A failure to obtain pre-authorization, we've discussed that. Lower level of care could have been provided. So instead of maybe having an MRI, we could have done an x-ray first to, rule out something. And so they may deny it because of that. And that kind of just comes with experience, If you, over time, you'll know that certain insurances may not cover the MRI. They may want you to have an x-ray first. Or if you do a pre-authorization, you're on the phone with the insurance company and they say, well, would they have to do a chest x-ray first before we'll do an MRI? So they'll tell you that, but a lot of times they won't, and you'll just you'll just remember over time. Let's see, a bundled service that's not eligible. A lot of things that are bundled are surgeries. So if you have, let's say, an appendectomy, a bundled service, we don't have to code for the anesthesia, the pre-op, the post-op. It's all one code and it's one fee. Okay. Now some things are not like that. Okay. And so a lot of physicians may try to unbundle and charge it separately. And so that's fraudulent, of course. So you have to be careful with that and make sure you know what's global, what is a global price and what's not. Because you may be accused of being fraudulent and you may not know that it was a global thing. Okay, going on to credits and collections. A credit, obviously all payments are tried to be collected at the beginning of the visit, but all the time that can't be, done. But there's different types of credit things we're going to look at. The Truth in Lending Act is really important, and this is it requires providers to make certain written disclosures concerning all finance charges. Okay. Then we have the Electronic Funds Transfer Act, which we already talked about. The Equal Credit Opportunity Act. So this is going to prohibit discrimination against, yes, I'll bill you. No, I'm not going to bill you. So that's what that does. The Fair Credit Billing Act kind of goes along with the Truth in Lending Act. Then we have the Fair Credit Reporting Act. So this is going to be a protection agency, basically, that's going to protect your information. And then the Fair Debt Collection Practice Act. So this states that third-party debt collectors are prohibited from employing deceptive or abusive conduct in the collection of fees. And so if you've ever had a collection agency call you and they do the bully method, that is considered illegal. Going on to collections, a collection account is also called a past due account or a delinquent account. You'll hear all of those words. When we want to see what accounts have been delinquent, we can do a report called an aging report, and it'll show us, print out an easy list. It's easy to determine, and we can bill the ones that are 60 days late, 90 days late, 120 days late. If you look at table 4.1, reasons to track claims, you have the down coding, which means a lower level code than is what's in the record. I don't know anybody that would downcode on purpose because it's less money, but you never know. Usually we may do this on accident. Then we have unbundling, which means when we have a bundle of codes, like for a whole surgery, it should just be one fee. And so again, some physicians or some unexperienced office personnel may unbundle it and charge everything separately, which is fraudulent. Then you have delinquent or denied. You have lost, the overpayment, which can happen, a payment error, like if the patient cashes a two-party check, in error. Pending or suspended or suspenseful, maybe they're investigating it more. Rejected claims. So those are all your different various reasons. Okay. So how to prevent delinquent claims? Well, you can verify the health identification at the very first part of the visit. You can determine each patient's coverage at the first part of the visit by looking online. You can electronically submit a clean claim to make sure that it contains no errors. You can contact the payer to determine if the claim was received. You can review your records to determine if the claim was paid, denied, pending, etc., etc. And you can submit supporting documentation along with a claim. And then we already talked about the aging report. I think we'll stop right there. You just make sure you look over the parts that I skipped. We'll try to touch on those in class.